I am here right now with somebody from the Christian Medical Fellowship. We'll come on to what that is in a moment. But let's say hello first to Susan, Dr. Susan Mariott, Head of Public Policy. Hello.
Hello, nice to be with you.
Now, there's a lot going on in that, which I want to get into. There's a lot to do with CMF, who I've known about for a very long time, not as a medic, just somebody who really has valued a professional medical perspective on certain topics, for which CMF has been brilliant with some of the articles they've written over the years. So let's just dive straight into this then. Head of Public Policy, what does that mean?
Yeah, so CMF, we're a membership organisation of doctors, nurses, and midwives. So there's 4,500 or so members who've joined. They're Christians, and they want to put in practice their Christian faith through their professional roles, working in healthcare. And one of the areas that we look at is public policy. So what that sort of means really is how the policies about how healthcare is delivered, what's allowed, what's not allowed, those kind of things at a kind of national or local level, are those in line with Christian principles, and are they therefore maximising the flourishing of our patients? And how can our members get involved in that? So we try and help members to think through things, so actually, we're going to talk about assisted suicide today, so it can be kind of hot button topics like that, but it can be things about prioritizing different patient groups in the way that clinics are allocated, or it can be all sorts of things. But how are policies at a national or local level being put forward in ways that do or don't maybe reflect a Christian worldview, that are as good as they could be, as good not as good as they could be? How can our members get involved in that, advocate for their patients, and also how can CMF support them in that? And then CMF at a national level, we do also do some things on behalf of our members. So we'll kind of respond to government consultations or Royal College consultations, some of the kind of bigger national level things. But a lot of it is about envisaging our members, equipping them, and supporting them in the ways that they really want their patients to flourish. And how can they do that at a policy level? How can they advocate for that in the different bits that they're involved in? So it's quite a varied role, quite a varied department.
Well, you've mentioned doctors and midwives, amongst
Mm,
others. I mean, already you've got very, very diverse bits of the medical field, and
yeah.
that's just doctors, which is a generic term for a whole host of people. So, yeah, I can imagine there's a few things that keep you busy every morning.
Yes, there absolutely are. Yeah. You never quite know what a day will hold. So, yeah, that's fun in a way too.
I mean, but the thing is that something you enjoy? Because some people would like to know, I'm going to do this, and at 11 o'clock it's that, and 2 o'clock it's that, and at 5 o'clock I go home. Some people love that. Me, I love the fact I don't know who I'm going to speak to next, and I absolutely adore that.
That's good. Yeah. Well, I mean, when I was a doctor, so I'm not working at the moment as a doctor, but when I was a GP, and part of what I liked about that was I didn't know what was coming through the door. So maybe this is a theme of my life. I don't know. Maybe I do gravitate towards jobs where you don't quite know what's coming in each day. So yeah, I hadn't put that together before, but maybe that is something that attracts me.
I think so. I used to drive trucks many years ago, and I met one guy who had the same job every single day for like 15 years. He picked up his truck, he drove to a particular hospital. I don't know what gas he was carrying. He discharged the gas, he drove home again, and he did it. And then one day, we want you to go somewhere else. Oh, well, I can't. No, hang on. I only know how to go from A to B. Yeah, but we want
Yeah.
you to go to point C. Oh. And he really got quite anxious and stressed because he got so much into this is my life, this is what I do. I kind of want you to do this.
Yeah.
Oh, hang on. But we're all different, which is
That's
what's
great,
fab.
isn't it? Yeah, it's good that there's horses for courses, isn't it?
Yeah, that's the phrase I was going to use exactly.
Yeah.
Right. So let's just look a bit more into your life then. So you're saying doctor, so that's GP. If you're in America, perhaps family practitioner would be the equivalent.
Yeah.
So general practice. What is the journey into being a GP? Do you sort of, because I met one person at school who wanted to be a doctor, and all I knew was they studied really, really hard at the kind of sciencey stuff that I just thought, yeah, that's not for me. But that's all I remember about them is they were very driven early on, thinking if I want to get to here, then I've got to get these qualifications in order to have a shot at doing that. So, what was your journey to becoming a GP?
Yeah, and it is quite a pathway actually. Like lots of professions are like that. But I think medicine is one example of these really kind of, it's a series of things, and you can sort of, some people pop out the other end and then wonder what's next, because it's been your kind of whole life for so long. But yeah, I think I first was interested in being a doctor as a teenager. I had a bad chest infection when I was sort of 12, 13, and I remember. yeah, just a few some of the health professionals I met to do with that, yeah, made me just sort of think, oh, so that's an interesting job. You're at that age where you're thinking about jobs, and I enjoyed science, and I liked kind of working things out and thinking about things, and because it took a few doctors a few goes at trying to get me better. I thought, oh, okay, that's what they're doing. They're trying to work out how to help someone using sort of sciencey things. That appealed to me. Yeah, so I applied to different medical schools, got a place. You do your kind of time at medical school, which for me was 6 years. Some people that's 5 years. And then you do general jobs, moving around doing those, before you kind of decide what area you want to go into. GP for me, it wasn't like I always wanted to do that. I kind of was interested in quite a few bits of medicine. And I guess in a way, that's why I ended up in GP, because it was kind of, all the different bits together. I already mentioned the fact that I quite like the kind of detective bit of medicine, so the kind of whodunit bit, which you get to do quite a lot of in GP, different every day, and you get to know your patients, and that appealed to me. I think some doctors say that's harder at the moment than it perhaps used to be. Yeah, for various reasons of the way the structures have changed, but that kind of idea appealed to me of knowing people, rather than just doing one-off consultations with people. Yeah, so then I don't know how together or many years that is, takes 10, 12 years or something, including all the different bits of the training. And then, yeah, and then they let you see patients by yourself in GP.
Yeah.
Yeah.
He's letting you loose. I remember the first time I'd passed my truck license and I was allowed on my own. And I thought, am I allowed to do this? Is
Yeah.
this so? The first time I drove on a motorway was the most weird thing that I didn't have a passenger. That
Yeah.
was the moment of, well, this is quite serious, isn't it? I know it's not
Yeah.
the same. It's not a doctor, but
No, well, yeah, it is. We all
it's
have
that
those
thing of
moments.
I've got my qualifications and now I'm allowed to do it.
Yeah.
And
Yeah.
oh, hang on, I'm
And
doing
now
this
I
on my
actually
own
have
now.
to do it. Yeah. 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 Yeah.
It's quite fun. Now, Christian Medical Fellowship, obviously the word Christian is in there. Medical bit we can understand, but just what's your faith journey? Where did God fit into your life, into what you're doing now?
Yeah, thanks. So yeah, grateful to God for Christian parents, and was brought up going to church by them, and yeah, speaking about God at home as well. I think I don't remember a time where I doubted the key facts, I guess, of the Christian faith. So I kind of always believed there was a God. I always believed, since I remember knowing it, that Jesus was God's son and that He died for me. I think the kind of doubt area for me really as a teenager was how it applied to my life, and whether and partly this related to wanting to being a doctor. I think I wanted to be a doctor. I was on a kind of pathway to get towards that. Did the Bible and Jesus, Paul, these kind of people who lived such a long time ago really have that much to say to me today about how to live, life, which university to apply to, or any of these kind of things, like how did those fit together? But I didn't walk away from faith or anything like that. But then at university, I went to a church where there were lots of other kind of young adults, and there was a real culture of being good to ask questions and wanting to think about things. And that really was very good for me in my faith. It made me be able to connect things more, realize how things came into the day to day. And also, I just read the Bible for myself growing up. It's not that I didn't have access to do that, I just hadn't really done it. And I read Mark's Gospel as a kind of young adult away at uni, and I just Jesus in a new way, and I'd heard about him a lot, but I just kind of reading it myself somehow, I just thought, wow, here is someone who really would be better than me at running my life. Like actually seeing the kind of roundedness and wisdom of Jesus as I kind of read through that gospel, and realizing, I guess, my arrogance in a way to think I kind of knew better about how life should run than him. So I think that was a kind of significant time for me being away at uni. And I think, yeah, I did struggle with various things in terms of faith and work, and how do you live out your faith at work? And I worked in Uganda for a bit, which then was very different because I was working in a Christian hospital, and that was very much more obvious. I could pray with patients day to day, and but what did that look like back in the UK? And so I did have various kind of struggles around that. But I think always behind that has been a desire in the different work I've done, and as I've already said, and it has changed around a bit what I've done, but to want to serve God in some way through my work. But yeah, CMF, we try and help people think about that, and I'm still on that journey too, I think. But the desire to do it is definitely there, and then working out the details has upped and downed over time, I guess. But yeah.
Fab. I want to keep moving towards the topic. We want to talk about assisted dying, but it's just I think it's interesting to have some of your journey into medicine. I think it's interesting to have your journey of faith because, of course, those two points at some point intersected, and then you found yourself working for the Christian Medical Fellowship. Used to be a GP, now you're working for them, and you're bringing lots of parts of your life together. So, just before we get to assisted dying, I think it'd just be useful. How did God get you into your role now?
Yeah, so I was actually doing a theology degree, so at Oak Hill College in North London. I was doing a BA in theology there, and I thought I was going to do a whole another year of that full time, and make it into a master's. But a number of people sent me a job advert for this CMF role and said they're looking for someone who's, a doctor, but also quite passionate about ethics, which I was, and has some Christian training or can speak on Christian things. And I'd also worked for a church and was doing this theology degree. And initially I thought, well, it's not the right time for me because I've got another year left of what I'm doing. But yeah, a few people sent it to me and prayerfully began to look at it. And then felt that I could see God's leading in how it might draw together a number of these different strands of kind of things God had made me passionate about, and I'd followed in different ways, but perhaps hadn't always seen how they could or would draw back together. And so felt a sense of, well, why not throw your hat in the ring and see what the Lord would do with that? And, there were steps between there, but yeah, I felt a sense of, God's leading perhaps in that. And so prayerfully put myself in to see whether others agreed, and they employed me. So here we are.
Fab. So you're now working for the CMF, Christian Medical Fellowship, head of public policy. Really, the main focus of today is to talk about assisted dying. Now, we've heard from Dr. Richard Scott, GP, current founding practitioner, general doctor, who talks about it from the perspective of a Christian current doctor. So what's it like in the day-to-day meeting a patient with this in the press? And he's already had some issues of this is making it difficult already for me. How do I even just talk about someone with a dodgy toe? It's got nothing to do with anything else, and yet it's impactive. Dr. Trevor Stammers, we looked at it from what's gone on in Canada and in the Netherlands, and how has that really panned out? What was their original intention? Where has it actually ended up? Where could it end up for us? And we spoke with Christian Concern, Paul Huxley, who looked at it from much more of a political perspective for the government and where they're doing, because obviously that's more what Christian Concern are interested in. But I was just fascinated, which is why I asked for this one, is your take from the CMF's perspective. Obviously, you're representing a very broad range of medical professionals. What's your take on the assisted dying bill in terms of how it plays into both medicine and faith, which is which is why you're passionately doing what you're doing now? So just give us a broad overview of what it actually is, because I think even the term that they're trying to use is very nicely misleading because it sounds better than it really is. Yeah. So what's your take on the assisted dying bill that we're looking at here in the UK at the moment?
Yeah, well, so the bill itself is aiming to change this the law so that the Suicide Act, which at the moment makes it illegal for someone to assist someone in committing suicide, won't make that illegal in some circumstances. So inherent in it is that it's about assisting suicide, which is, as you say, where they've got this euphemism of assisted dying that goes around, but it is about changing the rules so that sometimes helping someone to commit suicide would be allowed in British law, where at the moment that's not. And the particular group that they're looking at is people who doctors would give a 6 month to live diagnosis to. So they'd say, you've got this medical condition and we expect you might have 6 months to live, and there's problems with that. And we can talk about that. We're not very good at diagnosing that. So we're going to be getting that wrong a lot of the time. Probably about 2/3 of the time we'll be getting that wrong, actually, the length that we tell patients. But taking that as read for now, the group that they're aiming at is those people who've got about 6 months left to live, and to say, actually, you could request to your doctor, no, I'd like to commit suicide. And instead of what happens at the moment, which is that if you said that to your doctor, they would kind of put things in place to restore your hope and to try and move you away from that desire to commit suicide, that actually your doctor could agree with you after some different assessments that would have to happen by two doctors and the court. And that could be signed off. And then that first doctor could give you a prescription, come to your house perhaps, we don't know where exactly it would happen, with those drugs, and you would take them, and then they would stay around until you died. And so yeah, it feels almost uncomfortable even talking about it, doesn't it, when you put it in those stark terms? But that's the bill that's currently at committee stage in Westminster. And I think we're very worried about it. And I think for most of our members, while we can talk about the conscientious objections and all of that, that people are worried about how it will impact them, I would say most members I've talked to, actually the primary worry for them is their patients. Above all, they are worried about their patients. That's why they wanted to be doctors. They wanted to come and help people. So the biggest worry, I think, probably is some of the things you've been talking to Richard Scott and others about, that actually this is going to have a really negative impact on our patients, both their trust in us, but also in general, those who might be in that group, who might. So we know getting a kind of terminal diagnosis is a huge life event, isn't it? And people suffer psychologically when they get a diagnosis like that. There's a big, what we might call, if you give it a label, you might call it an adjustment disorder, or you might just say, at a lower level, just a kind of understandable, sense of despair, that might come up at that moment. And so people are very vulnerable, in that period. And so actually, we went into medicine because we wanted to give hope to vulnerable people, and we want to be those who, in that moment, restore hope to our patients and don't possibly agree with them, that their life, is not worth living, or and then, of course, there'd be groups who might not even be requesting it. So the bill actually actively would allow doctors to raise this with patients. So it doesn't even have to be coming as an immediate request from the patient. If this did come into law, we could even get the situation where, you get the terminal diagnosis and then you're given three options, and it's like option A is this sort of treatment, option B is go to the hospice, option C is the assisted dying. And actually, that to some of us just feels horrible. Having worked with patients and seen the way that they do trust us and they do think about the options we offer them carefully. Actually, I think I like that at the moment that's not an option on the table, and that someone in that situation doesn't have to justify living or feel, am I taking away inheritance from my children, or am I causing a burden on the NHS? They don't have to even make that
Mm.
calculation mentally. Whereas if someone like your doctor places that on the table, then you have to make that calculation, and it's, fundamentally placing a burden on patients who might not even have been wanting it. Yeah, so I think for the biggest reason for our members is their concern for their patients, and that this actually is going to be a burden to patients, and may see people committing suicide with the assistance of doctors who could have had hope and could have had some good times with family, and healing times, or times to reconcile with family members, even with the Lord. That some of those moments will be stolen, that could have been enjoyed. But we do also have kind of concerns about the conscience issues and what this might mean for doctors and their ability to work, and different things that we could talk about too.
I tell you one that you said earlier on, which you said we might want to talk about this. I think we should. Let me give you a bit of an anecdotal story and then a real time story. So I remember I was a stay at home dad for a long time, and I met a mum who had major problems with her children, who were just very unruly. They just seemed to be completely overly energized. And then one of her children had a medical issue, and the doctor said, right, you need to cut out these food groups to help this child. Now, as a mum, she then said, well, I'll tell you what, I'm not going to cut it out for this child. I'll cut it out for the family because it's a lot easier. So she cut out things like cheap fizzy drinks and lots of sweets that the kids were having, which she sort of got into a pattern. That's not really the point. But as she cut it out for this one child, and it helped her medically, all of her other children who had ADHD and hyperactivity suddenly didn't. And she realized, well, that sounds like it's probably the food that's creating this change in their personality, which she hadn't realized because, of course, they've grown up through it. Now, that's the anecdotal one, because you might say that's true or not. But here's a real one. So Richard and I chatted about this. Steve Legg, our friend who sadly died not long ago, he was given a very, very short terminal diagnosis for very serious cancer. He lived way past that. Now, that's not anecdotal, that's fact. And you said that you've got 6 months or less to live. 2/3 of those diagnoses may be incorrect. Can we just look at that? I mean, there's an anecdotal one. You can argue for or against it, and one that's fact, but we don't necessarily get it right when we make a conclusion. So how does the doctor say, right, you've got less than 6 months? How, not detailed, but how do you get to the point of saying that's the conclusion?
Yeah, so doctors are doing their best and
Yeah.
trying to kind of look at the evidence that they have in front of them, and sometimes patients are keen to know how long I might have. So these are, we're talking about patient groups that might have a diagnosis that we do know eventually that, they will die from that. And some people are not interested in knowing the length of time, but sometimes that is something people are concerned to know, and want to try and understand what that might be. But we're always guessing when we answer that question to some extent, and we're drawing on evidence to do that and doing our best. And, so you're sort of thinking, okay, well, on average, other patients you've seen or other patients in, studies and things, how long do they tend to have? But of course, that's a range, isn't it?
Mm.
So like the average is only right for maybe one person, everyone else is somewhere in that range, aren't they? And then you're also looking at the patient's trajectory. So if you've known them well, which is again a problem with this bill where the doctor seeing them doesn't have to be someone who's known them over a long period. They may just be meeting them on one day, and that makes this even harder. But if you've known someone over a few months, you might say, well, actually, week by week, you are getting weaker, and I'm starting to notice that. So, like a week ago, um, you could quite easily get yourself across the room, and now actually you're quite puffed out just going from the bed to the chair. And a week later, actually now you need someone to help you go from the bed to the chair. And you're noticing, oh, well, that's happening week by week. So that makes me think change is happening at about that rate for you. And so then that gives me an idea, where we might end up. So I think it's a kind of combination of knowing patients in general with your sort of disease, and then also looking at a trajectory. And that can be a helpful conversation to have with your doctor, in terms of your planning and, working out what sort of help you might need or what you might want to say to family, maybe family who live abroad, or, like there might be all sorts of reasons why that's a really helpful conversation to have with your doctor. But when you sort of bring into that, if you cross an arbitrary line of 6 months, you would kind of be admitted into this kind of ability to apply for suicide. I think that would have made me very nervous when I was working as a doctor, of sort of offering that kind of information to someone and sort of feel like, gosh, is that, this was kind of a suggestion rather than something which I expected something as significant as that to be sort of hung on to. And I think, I hope when we express it to patients, we do express that it's, an approximation on these things. But of course, people hang on to things that the doctor say, don't they? And can expect it to be exactly as they're told. But I would say every other family, or a lot of families will have a story of someone who what the doctor said was wrong in that sense, because it will be a lot of the time, because it's only a guess. And the study, yeah, they've done studies looking at it, and as I say, it's it's about a third of the time in that kind of middle group of weeks to months. We're actually much better at predicting if someone's within sort of a few hours or short days. Then that's sort of a bit more obvious often, not always, but often doctors are a bit better there. But in that kind of one where it's kind of weeks to months, in which the 6 months one would fall, it's actually very difficult to say definitively. And some things we don't know. God knows. And all the days of our life are written in His book before one of them comes to be. But doctors don't get to look in that book, and we don't know. But yeah, so there is an art rather than a science, and not a precise one.
I don't know how far off this is, but I think of weather forecasting being incredibly complicated. We have these massive supercomputers, and we know that if it's this temperature and this humidity and the wind is this direction and this speed, therefore 100 miles away, it should be this. And yet, how often do we think, well, where's the snow? Or why is it snowing? You said it wouldn't. Or we have the big storms going back, a long time ago. Yeah, don't worry, it's not going to be a problem. And then we have the worst tornadoes ever in the UK on history, kind of thing.
Yeah.
Is that similarly equivalent of forecasting to what you're talking about? Because I would say the human body is even more complicated, because then we're also sticking in medications. I had some medication because I had a heart issue at one point. It wasn't quite the heart issue they thought, put me on some medication, caused all sorts of other problems that required medication, and I think actually potentially surgery later on, which I had last year. But this is all quite in my mind, because I was having heart surgery last summer. And it makes me wonder, is it even more complicated than the weather? Because then you've got mood and feeling and how positive you are to live. And, I know that must be a part of it. So how equivalent is something as simple as that?
I think that's a good kind of analogy, and as you say, there's a lot of complexity with human beings. You mentioned a couple there. Also, another one is what environment you're in. So sometimes, you'll see a patient in hospital if you're a doctor working in the hospital, and they can seem quite badly off, and you think, okay, well, actually, it must be quite close. But then they get back to their own home, and perhaps their GP goes to see them on a home visit a week or so later, and they've perked up a lot, having their own food and their own
Yeah.
environment with their own family around them. And then you think, well, actually, I'm not sure it's quite as dire as the hospital doctors were saying. Maybe there's a bit longer here than they thought. Yeah. So again, environment would be another one, along with the ones you mentioned. I think there's just a lot of factors that make this definitely not a precise thing to be able to predict.
Which really comes down to one of the, I suppose, the fundamental flaws that I see as a non-medic in this whole thing is you can't state accurately. Nobody can, right? You have less than 6 months to live because, well, we don't know that. We can assume it, we can forecast it, we can make an approximate guess based on what may have happened in other people who are not quite the same as you. But the simplest sort of understanding of this is 2.4 kids is the average. There's no such thing as a zero point 0.4 child. It might make sense statistically, but we're not statistics. We're people. We're human beings with lives and hopes and dreams. So the whole thing of you've got 6 months, then you can fall into this category. Now your doctor can say, would you want us to help you kill yourself? Which is what we're actually talking about. If we're wrong 2/3 of the time in that because we can't be any more accurate, and I would say the doctors I've met, I've never met a doctor who isn't caring. Let's put it that way. I've met quite a few. They always seem to have compassion. Otherwise, they wouldn't be in the level and where they are. But even with the best one in the world, if we can't accurately, factually state you have less than 6 months already, for me, this bill is massively flawed because the very premise of it will never be proven.
Yeah. And I think that's right, isn't it? It is arbitrary, the group that's been chosen, and it's a group we can't even really define. There's no particular reason why suicide prevention should not apply to this group. They can feel suicidal for just the same reasons as any other person. They're not fundamentally different to other people. They're just a group of people who, roughly speaking, and getting it wrong some of the time, doctors might be saying, this is how long we might expect you to have left. They can feel despair and hopelessness, and they can feel a burden to others. These things that we can experience at other times of life as well, and that at those times society meets with suicide prevention and trying to give hope and care, and not always perfectly, and we want to work on doing that better. But I would say, yeah, this group it's an arbitrarily chosen group to say, that they should be treated in a different way, which isn't kind of looking to offer them best care and compassion and walking alongside in this period. Of course, the dying period has some particular needs, and palliative care and good social care and good family care are needed in particular ways in that. But actually, the need for wraparound care for those who are feeling like life is hard. It's the same at all stages of life, and this group are kind of no different. And the imprecision of defining who the group are kind of highlights that in a way. What we've been discussing highlights that this is an arbitrarily chosen group, which is some of the concern Trevor may have talked about in Canada and how it expanded. Because if you kind of arbitrarily choose a group, well, immediately that leads you to say, well, why not someone else? Why not 6 months and a day? My doctor said I have 8 months, but we know they're not very precise at that anyway. So maybe it could be 6 months. Why this group? Why limit it? And that's some of what I'm sure Trevor will have highlighted about how things have expanded in Canada. So I think we're highlighting one of the quite fundamental flaws with the bill. Yeah.
I mean, one of the ideas of this, and we touched on abortion in some of the conversations because it's very, very clear, it's very safe. We're going to make sure it's like this. There's two doctors and a judge, which is what we're talking about with assisted killing. Assisted dying. That's not me being silly. I know what it is, but actually, it's really complicated to define it. One of the things that Paul Huxley from Christian Concern said was, great, so we've got these two doctors and a judge. The court system is already completely overswamped. So he said it's not going to be two GPs because that won't last long, and it won't be a judge. The judge won't see the GP stuff. They haven't got time. Oh, yeah, fine, we'll trust them. And all of a sudden, you've got non-doctor accredited decisions because they haven't got the time. GPs are stretched, courts are stretched. Paperwork, messes. All of a sudden, we're killing people off who didn't have any knowledge of what was going on because it's been signed off by someone who didn't even read the paperwork because they haven't got time because they're already overswamped. That was one of their concerns. I mean, how can a GP in a practice help their patient protect against that? Because the other thing he said, which was fascinating, was normally now somebody says, I'm basically suicidal, I'm going to die, therefore what do I do? The GP's first reaction is, okay, how can we help you with that? How can we get your mind off wanting to end your life to wanting to live today, tomorrow, and as long as you have. How does that impact the lives of the medics that you're representing, who are now faced with a patient who's walking in saying, "I've been given less than 6 months, I want to kill myself," and now they're switching from compassion and care to killing?
And I think that's one of the, when you do look at the kind of conscientious objection elements of the bill, so that's one of the ways that it just doesn't work, because it's not just another medical procedure that I don't want to do because it might damage my conscience, so it's not like that. It's actually fundamentally about the nature of my interaction with people.
Mm,
And so if a patient said to me when I was working, or says to one of our members who's concerned about this, yeah, as you say, I'm feeling so low I've had this diagnosis, and, oh, it's just a grind now and I'm feeling fed up with it. Um, I want to hear that, and I want to tune into that, and I want immediately to reflect to them how valuable they are and how much it is good that they're in the world and that they receive support, even if it's costly, around them, and that they're worth that.
mm,
And from a Christian point of view, they're made in the very image of God. They're valuable, and we want to help them to live until they die. And so to even introduce the idea that, well, of course, you do have a legal right to suicide, and I'd be happy to refer you to my colleague about that. I personally don't do that. Even that conversation to me feels like I'm treating my patient wrongly. It's not about just me have there's an arbitrary law that God has put in place that I don't want to break, but I'm happy, fine, you go do it with someone else. My duty of love compels me not to want in that moment to even introduce the idea of referring you off to someone else. And so it's fundamentally cutting at the heart of compassion and sort of asking people to somehow close off their right and good loving response to hearing someone's despair by introducing the possibility that maybe they're right. Maybe they're right to despair, and maybe it would be better if they were dead. Yeah. So I think it will be a fundamental shift in the way that people are being asked to interpersonally interact with a patient, in a way that will be intolerable, and feel, you know, yeah, people will be unwilling to do it. Some people, I think. Some people may feel they ought to do it because it's what they're being asked to do by their employer, but I think it could be very damaging to them and put a huge strain and burden on them in kind of asking them to behave in ways that actually there's a dissonance there for them, because it feels morally wrong, and it is morally wrong, I would say, but it feels wrong, but they're being asked to do it. And there's something very damaging to us about that. I haven't looked into it greatly, but there's a concept of moral injury that one of our members is writing about.
mm,
And that actually that can be quite damaging to people, contribute to your own mental health issues, or strain on your life as well as a person. So I think this is a very wrong thing to be required to do, to be required to kind of treat someone as you believe is actually fundamentally unloving, and to be asked by your kind of employer or your government to do that, I think is a very wrong thing. That's not something the state should have the power to do, to compel us to behave immorally and unlovingly, in our view, towards another. And particularly for doctors who, this has never been part of healthcare,
mm,
since the Hippocratic era. Actually, the doctor has fundamentally been someone who is for life and who would never kill. And that has been, yes, so fundamental to a doctor's self-understanding, and to the patient's understanding of the doctor. So to ask us to twist that role, and to make the doctor potentially someone who would agree with you, and offer you the means to kill yourself, could cause great harm to physicians as well as obviously patients in ways that we've been discussing.
mm. I mentioned I had heart surgery last year, and there were times when I was very low. There were times where walking up the stairs was really hard. Now, I wasn't suicidal. I didn't have that sort of an issue, but I definitely wasn't on the happy isn't life great thing, because I'm recovering from, it was actually an ablation, so burning the inside of the heart. Okay, it wasn't other things it could have been. But even then, I was reflecting when this started to come into the press and thinking, can I trust my cardiologist and my surgeon? What if they think, oh, we can't bother, let's just kill them? Because that thought actually did enter my mind. Now, that's not a thought I ever thought I'd have to think of. Can I trust, if I go to my GP and saying, I've broken my ankle, what do I do? That I've got a cast on from the hospital, but what do I do? Now, patients actually do have to have the same sort of thing you're talking about, this mental process going on of, or what if the doctor thinks, well, you're a bit old, you can't walk again, let's just, let's go for assisted suicide. All of a sudden, that's a really real conversation. And it hit me so hard having heart surgery. I think I'm now completely at the mercy of a surgeon. I mean, I was conscious, but I was sedated, so I'm sort of out of control of anything that's going with my body for those couple of hours. Or what if the surgeon got bored and thought, I will kill this one off? Oh, well, they wanted to kill themselves. That thought, actually, as ludicrous as it sounded, is no longer ludicrous in terms of what we've seen with overreach, especially in Canada, which is what Trevor talked about. It's like you said, it's this small minority is all we're going to do, and then suddenly they're offering people, well, you're getting a bit old, you've got a bit of problems, should we just kill you off? It's cheaper for the state. The fact that even has said, well, how did we get there? Well, it's because we opened a door over here. Otherwise, we could have never got to that point. And I find myself baffled and perplexed that we're even having this conversation, and equally passionate of trying to have this conversation, because it is unbelievably destructive to everybody in society when a doctor who we go to because we're not very well is now having to have a consideration of, well, might they die in 6 months? So am I now obliged to tell them to kill themselves? I mean, how do you help your members as a CMF to navigate this minefield of minefields, and, like you say, maintaining that mental health that's good, that we want our GPs to have, that's now seriously in question?
Yeah. I think one thing is, obviously, my big desire is this doesn't come into law, and there's, still ways that we can be opposing this. But if this was to come into law, one thing I think absolutely that needs to be in the bill, and we put this in our submission to the committee, is that there need to be not only a kind of individual right of conscientious objection, but an institutional right of constitutional objection, so that a whole GP surgery can say, we are assisted suicide free. So you won't be offered that here. None of our doctors are going to do it. They don't want to, doctors who come to work here will understand this is an assisted suicide free practice, and patients can all be told that. And patients then who do feel anxious can register at such practice, and then they still can see a doctor that they feel confident. Well, I know my doctor would never offer me that. They're not involved in that. So I don't have to have that worry with them. I can think of them like I used to think of my doctor, and I would want that also for hospices, for nursing homes as well. My carer at my nursing home is never going to bring this up for me. Is never going to offer this to my granny. Like, actually, they wouldn't be allowed here on this premises. They're not going to have the death doctor coming into another patient in another room that granny has to hear about and be distressed by. Actually, we're an institution who won't have that. And I think, I think we can still defeat this. So, that's, number one is to let's get this voted out. Let's not have this. But if it were to come in, I think giving whole institutions the right to conscientious objection will enable there to be safe spaces for patients who maybe have had suicidal thoughts on and off for their whole life, and are now fearful of going to present with their cancer symptom, because they think, well, if I get a terminal diagnosis, the doctor might offer me suicide, and I've been fighting that my whole life. And if everyone starts to say that's the right thing, I know I won't be able to fight that anymore. Or a patient who, is disabled and has experienced negativity from others a lot of their life, and has felt that actually there have been times in their life where they have been treated like their life isn't really worth living, and they fear that coming into the way that they interact with healthcare more, or they fear, I'm going to be offered this, assisted suicide. So I want to choose to engage with healthcare still, but that feels hard to me now. I know that this is going on there. Oh, but there's a safe space. There is a GP surgery, there is a hospice in my town, that I can know I can go there to receive care, and that will be a safe space for me where this won't be offered to me. So I think that is something, we really need to, if this were to come in, which I'm hoping and praying it won't, something we need to advocate for all patients, so that there are spaces that are safe for them.
I love that you're interacting at a level that me personally I couldn't interact with, and it's great. That's why I love people like you, like Christian Concern, like Evangelical Alliance, like the CMF, who can get involved in government conversations at a level that ordinary people can't, because I'm not a medic. I don't understand. I would have never come up with the idea of, well, we want it not to happen because it's evil, but if it does happen, then at least there's a doctor's where you're not going to be asked, do you want to kill yourself when you walk through the door? The fact we're even having that conversation is mentally odd, honestly.
Yeah.
but we are in a place in society because it already is in the world. Canada have embraced it, it seems rather sadly. The Netherlands have embraced it clearly. I really hope and pray it doesn't happen in the UK, but I'm encouraged that you at least have an idea
Yeah.
that could safeguard patients, that could safeguard our medical profession who are already under strain. We don't need more mental health problems in this United Kingdom. We don't. We've got enough of teenage suicide and young kids wanting, it's enough mental health. And I'd love to find a way of physically preventing it, but that's beyond my personal ability. But me as a group, actually we can. Me supporting people like CMF. How people, what practical things can your members do with CMF to help prevent this?
Yeah, so we've encouraged all of our members to think about putting evidence into the committee. So any doctor or nurse is an expert, and they've asked for experts to submit evidence. Any of your listeners who are lawyers or social workers, they are experts. They have expert evidence that they can submit. And you mentioned Christensen's Concern, also Christian Institute have put out some guidance on that. CMF have sent out some stuff specific for our members. So there are, ways to engage at that level. I think another thing is just to make sure you're informed about this. So CMF are running a course for our members, a sort of 4-week course. People can, it's on Zoom, they can come along and make sure they're informed about this so that they can open up the conversation in their workplaces, around them. Because I think some doctors maybe haven't even had time to read the bill, so they don't know the details of what's being proposed. And whatever faith background, therefore, I think that's true. Christian doctors, non-Christian doctors, other faith backgrounds, and some of the details of the bill shock doctors when they actually hear about them. And so there could be more doctors who actually are opposed to this than realize they are, because maybe they, don't have a faith background that gives them that kind of strong moral framework, and they don't instinctively have a position on this. But if they heard more about it and understood more about the details, which could happen by Christians in their workplace opening up that conversation. Also, there's so Care Not Killing are the kind of one of the campaigning groups they're not specific to a faith, but they have a sort of branch called Our Duty of Care, which is aimed specifically at healthcare professionals. And we've encouraged our members to look at what they're doing and consider getting involved there. So that's a way that doctors, nurses, and other healthcare professionals can kind of add their name to a group and say, we of whatever faith background, it's not about that, but we together do unite around the fact that we're opposed to the intentional killing of patients, and they can sign up to that, and that group will help them to know how best to express their concerns, and can sometimes speak on their behalf to express the numbers that are on. There's many thousands signed up there. I think a key thing that everyone can be doing is engaging with their MP. So we all have an MP, and they're going to get another vote at the end of April, and in the first kind of time this was in Parliament, a lot of the MPs said, well, this is kind of about the principle, but we'll see the details, and then once the details have been hashed out, we'll make our final decision in that next vote. So we need to hold our MPs to that and say, okay, whichever, even if maybe they voted for it in the last one, actually, okay, now have you really looked carefully at the details? Here's a detail I've heard about. Have you really looked carefully at this? Does that, really sit right with you? Can I tell you my concerns about that? And doctors in particular and nurses have a particular opportunity to speak to their MPs about this, because we have experience that the MPs in the main, if you do, but in the main don't have, of, like these interpersonal interactions that it sounds like you've talked about with others, actually just how much patients do feel the need to do what pleases the doctor or do what is best for the NHS, or we know that that's a reality. We know that patients apologize to us and say they're sorry for taking up our time. We have those day-to-day experiences that help us to understand how this could be a vulnerable interaction that could be misused and could lead to people feeling a burden and feeling they ought to do this. And so we can tell those stories to our MPs, because they may not have had those interactions, which just doesn't make them, bad or wrong. It's just that maybe they came through a kind of finance background or another background, and they haven't had, those kind of health interactions. So I think any doctor or nurse or other health professional has an opportunity to ask for an appointment with their MP. We're allowed to do that. I got to meet with mine. Many other members have been able to do that. And we can do that ahead of the next reading and just explain, know the details of the bill and explain to the MP, look, here's an example of a patient I've seen and how I think they would very easily have gone for this, just to kind of, not that any one individual was kind of coercing them in a kind of direct way, that although that can happen, but that just the general pressure of feeling like a burden and feeling like a bit much, would have led them just to accept this if I'd offered it to them, even though actually with help and support, they could have had, uh, another number of months or weeks, which were valuable and, which it was good that they had. Um, and that without this bill, they would still be able to have. So I think interacting with MPs is really the key thing. I think I would encourage anyone towards. And praying. I haven't said praying. Everyone should pray.
Amen to the praying.
Yeah.
I guess it's one of those things where we can passively shake our fist and say this is wrong, we're morally outraged, or we could actually write to an MP and say, actually, we do live in a democracy and we actually do have the capacity to speak to the people who are going to make this decision. And if I did it on my own, maybe that's not much of an impact. But if 4,500 doctors, midwives, nurses suddenly started taking up the time of the MP, that's quite a lot of impact. And we either think, well, we have nothing we can do because it's too big for us, or realize that as a group of people, there's quite a lot we can do actually.
Yeah,
And it's encouraged that you're not just saying, well, pray about it. Actually, you'll come up with, as I would expected, a bunch of stuff that can be done. If you're a medical professional, then get yourself the CMF Zoom thing and learn about this, because it's probably quite big. I'm sort of cynically convinced it's probably quite big, so people don't read it. But then people will, and which it never actually works. So yeah, do something. Don't just sit there and think, oh, this is evil, this is terrible. Do something, and do it politely and do it compassionately.
absolutely.
Don't fight for yourself, fight for others.
Yeah, and I think that's one thing, is it? So who are the voices that are not being
Yeah.
heard? And can I help to magnify them,
Mm.
actually? And often that is, elderly folk who maybe, wouldn't get round to writing to an MP or quite know how to do that, but might feel quite fearful of this.
Mm.
How can you amplify their voice? How can you make sure your MP knows that actually there are people who this makes feel frightened? Or patients you've seen, if you're a healthcare professional, that actually they would have been very vulnerable to a subtle pressure towards this. Like, how can you amplify their voices? And that's by telling their stories, isn't it, in a appropriately anonymized way to the MP, so that they can vote. Because sometimes we hear kind of trigger stories that pique our compassion in the other direction. And I would say often it's very well meaning that people kind of support this kind of bill. But actually their compassion is being rightly piqued, but this is the wrong solution because it brings with it so many other devastating impacts. But actually we want to keep fighting for good solutions for those few cases, but also magnifying the other devastating consequences that come from this wrong solution. And so, yeah, doctors, midwives and nurses have a particular opportunity to be a part of that, I think.
And if you're a church leader, go and speak to your older folk who you're
Mm,
probably looking after. Gather it as a vicar. Take it to your MP, because you do have the ability to speak
yeah.
in a way that they may not be able to. There's another one.
Yes. Yeah.
Thank you. We're out of time, really. I find myself with this topic baffled that we're even having a conversation, not wanting to even consider it or think about it, because it's so, me personally as a Christian, it's just so evil. I can't even conceive it. But irrespective of that, we need to have this conversation, because we need to do something as Christians. And we cannot just say in 5 years' time, well, that was terrible. Well, what did you do about it? Well, I said it was terrible and I prayed about it. Great. But do something. Pray and do.
And
Don't
do.
just pray.
Yeah.
And if you're not sure what to do, get hold of Christian Concern, Christian Institute, Evangelical Alliance, Christian Medical Fellowship. Find a Christian group. Probably they've got a statement on it already, or they will have very, very soon. If people want to get hold of you, perhaps because they're a medical professional, they just want more like I did. I'm not medically minded at all. Don't do science. But I was fascinated by some of the stuff that you guys put out, because it's from an interesting perspective, which I found often very helpful. How do they get hold of CMF?
Yeah, so we're on cmf.org.uk is our website. We've got blogs on there, and you can contact us through that. If you're, interested enough to want to get our emails, you can sign up as a CMF friend, whether you're a health professional or not, and you can get kind of emails quarterly from us, just If you particularly ask for the public policy updates, you'd get the ones that come from me, or you can get more general just updates of what CMF are doing. And if you're a doctor, nurse, or midwife, become a member. We would love to have you join us and get more involved in local groups or conferences, or these Zoom meetings, different things, ways outside public policy as well. Lots that's on offer. But we would love you to join us and put your name alongside others who care about living out their Christian faith in the workplace. Yeah, so come become a member if you're able.
Thank you. I'm not enjoying these conversations because of the topic, but I am enjoying the fact that we, as a radio station, can at least do a little bit of raising the profile and trying to get some people who may not have heard about it or thought of something that they could do. Oh, here's some ideas. Dr. Susan Mariott of Public Policy from CMF, thank you. And I just pray you'll keep on coming with bigger and better ideas to defeat this, and supporting your members in the process. So thank you for your time today, and just bringing us a really interesting perspective from that of the Christian Medical Fellowship. Thank you very much.
Thanks very much.